My name is Michelle Stefaniak, and I'm a member of the Villanova University Alumni Board of Directors. I have the great honor today of kicking off this session and welcoming you and our panelists. So with that, I'll jump right in. Today's session is entitled America's Healthcare, Getting It Fit and Fiscally Sound. I'm honored to introduce our panel. Our panel moderator is Dr. Patricia Haynor, Associate Professor and Coordinator of the BSN MSN Gateway Program for Registered Nurses in the College of Nursing. Our alumni panelists are Dr. Tara Cortes, the past president and CEO of Lighthouse International and a member of the University Board of Trustees. And finally, Sandra Myers-Gomberg, the Interim Chief Executive Officer of Temple University Hospital. Thank you very much, and please enjoy the session.
Good afternoon, and welcome to the College of Nursing and Driscoll Hall. This is unusual for us to have 3 mics up here. Let me walk just a little bit further away. We were told not to hug, otherwise something would happen. So I may have been too close to you, Sandy.
Sorry.
Our challenge today, I think, in the 45 minutes or so that we have together, is to really take an opportunity to see if we can upset the apple cart, turn it upside down in terms of what we have known as healthcare in the United States. I'm going to step back for just a second and give you some of the headlines that we've been looking at just in this last week. And as recently as this morning, the healthcare guidelines in the New York Times read, "Healthcare bill gets green light in cost analysis." A good place to be, maybe. The Congressional Budget Office said there's enough money in terms of what they thought they were going to save. They're only going to spend $823 billion instead of $900 billion, or almost the trillion. And you've probably read some of the numbers. It's going to cover 25 million of the uninsured instead of 45 million or whatever the number is that's been out there. We've also seen this week a headline also from the New York Times that said waves of new fund cuts in Medicare for nursing homes were going to take $16 billion out of the Medicare reimbursement in that field over the next 10 years. Probably a more exciting headline was one that was earlier this week in the Philadelphia Inquirer that read, "Medicine that works. The German system values healthcare as a right. Only 0.1% of their population is uninsured. It's not a government program. It's supervised by the government. And it's financed by something Americans would find unpalatable, I think, 15.5% of a shared tax between the employer and the employee." The Wall Street Journal, Pennsylvania actually made their news this week. Hospitals find a way to make care cheaper and make it better. They presented successes in Pennsylvania. One of them notably is the significant decrease in the infection rate in our hospitals in Pennsylvania, and also their quality results that they publish quarterly and yearly that people like the Philadelphia Police Fund has actually used to select the providers in the city of Philadelphia, and has saved $5 million a year by basing their care and sending them to quality providers, whether hospitals or physicians or other services. The Hershey Company also saved 50% of their medical expenses over the last several years by doing the same thing, by landmarking who were the quality providers. And interestingly, early on, they did not use the Hershey Medical Center. Dr. David Nash, who's from Thomas Jefferson University's School of Population Health, captured this and said that actually high quality really costs less, and it always will. And the New York Times tells us again that the overhaul is drawing close to getting to the floor, and we know that from the news today. On that note, let's take on our challenge as a panel and as a group of colleagues who we're going to discuss what's going on and see what we can come up with for fiscal health. In your rows, the alum that are in the room have for you a handout that looks like a justice scale, and that was deliberate. Without slides, sometimes it's hard to visualize stuff as we talk around it. And what we have for you is the justice scale, which on one side has misuse and overuse, and the other side talks about underuse. You will also find them giving you a handout as a reference list where many of us has taken the material from that we're discussing today. My caveat is most of the information I'm going to offer to you is really from other experts, just to give you more information to think about. Underuse was described by the 1998 Institute of Medicine Roundtable on Healthcare Quality. Now, you're probably saying to yourself, but Pat, that's 11 years old. If you read the report that was presented in 1998, sadly, the problems that they brought to the surface are still the same issues. So what they said in 1998 is still true in 2009. Underuse by definition from this group was a failure to provide a healthcare service when it would have provided a favorable outcome for a patient. Simply, and this is something that Tara's going to get into, like missing a childhood immunization, prenatal care, undetected and untreated hypertension and diabetes, failure to use effective treatments for heart attacks on arrival in the emergency room, something as simple as an aspirin. Overuse occurs when a service is provided under circumstances in which there's potential harm exceeds the possible benefit. Their example was prescribing an antibiotic for a viral infection like a cold, for which the outcome is usually ineffective and constitutes overuse. Now, there are some other issues around that, but that is a basic example. Misuse occurs when an appropriate service has been selected, but a preventable complication occurs and the patient does not receive the full potential benefit of the service. A simple example of this would be a patient suffers a rash after receiving penicillin for a strep throat, despite having a known allergy to that antibiotic. Misuse is not synonymous, though, with errors, because not all errors result in adverse events or injury to the individual. Very simplistically, the imbalance depicted in the justice scale illuminates the issues we are facing in healthcare reform and gives us a starting point to discuss the challenge to leaders to balance or disrupt the current system. Sandy Gomberg will offer some insight on financial situations that are currently in play both in the House and the Senate, and she tells me she has some show and tell as well. Tara Cortes will balance the scale with models of care on the underuse side. We will then come back and I will offer some expert views from physicians, insurers, economists, and nurses. And our presentation should take somewhere between 15 and 20 minutes, and then we're open to the floor for give and take. Sandy?
Sure. It's a privilege to be back here at the School of Nursing and with Dean Fitzpatrick and my colleagues up here, and I appreciate the invitation. I did bring show and tell, and as the nurse who is an administrative person, I bring you the Wall Street Journal, and I'm going to use it as a framework to talk a second about what I think is the undiscussed financial framework about how we're looking at healthcare right now. And I'll call out 4 things. This is from Tuesday, and the front page article is the article that Pat referenced, which is hospitals find hospitals find way to make care cheaper, make it better. And it's an article about the Pennsylvania Healthcare Cost Containment Council. Largely, it's budget cut under the current Commonwealth budget challenge. But in fact, what it does in the Commonwealth of Pennsylvania about providing information to consumers, albeit 3 years late, about healthcare cost and quality. In the middle of this section, was the front page section, is the article about the Nobel Prize winners, whose research was really focused on aging and the little microscopic pieces of DNA that control our aging and how cancer happens. At the end of this section is actually an editorial by a dad who writes about his son's leukemia, and that the magnitude of non-FDA research in a clinical trial extended his son's life for some handful of years, but the boy died in his young life. And back on the first page is a news clip about how hospitals and insurers are pushing back against changes to a Senate bill that eases penalties for not carrying health insurance. So a tiny flashback in financial history. You know, healthcare, organized healthcare really didn't start to happen until after World War II and the Korean War, when folks came back from the war and the federal government began to step in about organized healthcare. And Hill-Burton was a bill that was enacted that gave the money to make hospitals. And if those of you who are from the urban Philadelphia region, you know there was a Catholic church and a hospital in every ethnic community in the city of Philadelphia. And that's how communities grew up, because in order to get money under Hill-Burton, you had to put hospitals in places of viable economic stability. It came with a lot of rules, like you had to provide free care, and when Medicare and Medicaid came into being, you had to make sure you took Medicare and Medicaid. And there began the age of healthcare. In the 60s, the NIH was developed, and all of a sudden, because hospitals needed more doctors, it became sexy to be a doctor. My son, the doctor, you know, it became a very big thing to be a doctor. And so medical schools started to proliferate, and in fact, that's when the NIH, tied into medical education and research, really started to come into being. And as we improved people's health care, it became a brilliant success, and people wanted more access, and the birth of private insurance happened as early as the 20s, but really came into being in the 50s and the 60s, and the private insurers like Blue Cross came into being, where some really smart people said, we could probably get people to pay us some premiums and underwrite their health care risk, and this could maybe be a good business venture for us, and that happened. Once we roll into the 70s, and every decade since then, the federal government and those of us in healthcare who are obligated to maintain our stewardship responsibility to patients have had arguments about how we reduce cost. Because that brilliant success of clinical research and more doctors and more access to healthcare had lots more utilization happening. So in the 70s, in the Nixon era, we had wage and cost controls. In the 80s and the Carter era, we had healthcare cost caps. Rolling into the Reagan administration, when we see DRGs roll in between the 80s and the 90s. Each decade, we've had something that happens in the financial sector and the public sector that tries to tackle this ballooning cost in healthcare. And in the end, it's all about more people using it. So as we roll into the 90s and we're living longer, babies born today might be living as long as the age 100. We've added 20 years of longevity and therefore healthcare utilization needs to a large portion of our population. And so it's not as much a failure of the system, but is our failure of understanding what about the system needs to change in order to try to control costs. And I'll throw this last point out, 2 points. One, for those of you who are in public companies on Wall Street, or you read the Wall Street Journal and you have investments out there, right now there's a lot of speculation about those stock prices who are pretty highly valued. They look like they're coming back. And I think this next quarter is going to be kind of tricky, because the analysts are saying, you know, if those stock prices are valued because those businesses did a good job taking out costs, it's not going to stay there. It's not sustainable. That particular business is going to have less value in the coming months. And so they're looking for top-line growth. Healthcare and hospitals, although an awesome stewardship responsibility to deliver care to people at their most vulnerable time, still have to play in that space of whether or not we can manage simply by managing cost out of a system and ignoring the obligation of top-line growth. And what I'll assert to you is that largely the fringe of what we're playing with right now in the national playing field is looking at the insurance companies' top-line growth and saying, you guys can't have different premiums for different risk categories, and you guys have to figure out how to cover all these people. And it's saying to hospitals, you know, right now Medicaid pays us 80 cents for every dollar of cost, and you know what? We're going to drop that down because we're going to use it to cover more people. They're playing in our top line. And just like every decade before this, we're going to respond as an industry. We're going to try like heck to make sure we honor that stewardship obligation and do it under the premise of good quality health care, which my colleagues will talk about. But in the end, unless we systemically change the delivery model, which the federal government is not going to be able to do by talking at the top line, we will continue to balloon the cost up. And in a decade from now, my daughter, who maybe will be in med school by then, will be arguing the point of how that didn't happen this time. And so systematically, I would argue that what is really needed are the kinds of changes that both science and technology can offer us, things like a lifetime medical record. And I'll just ask a question, because I think, Tara, it'll go right into your thinking. How many people in this room, if I asked you, could put your hands on your complete health record? Every ER visit, every lab test, every x-ray, colonoscopies, mammograms, you name it. So that is the elephant in the middle of the table. By virtue of that, every time you see a provider, we do it all over again. Because in the absence of tort reform, we are too frightened not to. And so moving forward, while we will live through Baucus's bill, Senate Bill 850 in the Commonwealth of Pennsylvania, and whatever else is going to come out of the Commonwealth's negotiations, we will ultimately have to tackle that. So we will need an automated medical record that is portable anywhere, that has tort reform so that clinicians can rely on each other, and the place the federal government needs to play is articulating standards about what's normal and abnormal. And then therefore we can get to the business of decreasing utilization, which is the appropriate way to attack the bottom line. With that, I'll pass on to my colleague.
Well, thank you. Thank you, Sandy, for those very interesting remarks. And it is indeed a pleasure to be here as part of the inaugural Leadership Summit here at Villanova University. And it's wonderful to see the people who are part of it. We certainly do have tremendous leaders who have graduated from Villanova University, and it's a university we are all very proud of. Well, building a physically fit and fiscally strong healthcare system. That was the task it was a topic as how we were going to do this. I thought, well, this is certainly no easy task, and Washington, as we know, has spent decades and decades and decades trying to figure this out. So what I will do in the next couple of minutes is try to address some of the demographic changes that have really impacted our healthcare delivery system, and just posture a few suggestions, a few ideas about some of the changes that need to be made if we are going to have an effective quality care system here in the United States. We hear all the time about foreign countries who are above us, over us, better than us in terms of the delivery of care. What do we have going on here? Well, first of all, some of the problems have been illustrated here by what Sandy has said, but demographically, what's happening? We've got the graying of America. We have a worldwide graying, but if we look just here at the United States, we have the baby boomers who are turning 63 this year and are going to be hitting the older ranks very shortly. And we also have people living much, much longer because of biological and technological advances that have made medicine such a much more, a better way of prolonging life and keeping people at a higher quality of life. So number one, people are living longer. We are going to double the number of people age 65 and over by 2030. The Institutes of Medicine predict that we are going to have, we have about 35 million people 65 and over today. By 2030, we will have nearly 70 million people in that age category. That's a tremendous number of people. As Americans live longer, they also have a lot of chronic health problems. High blood pressure, hypertension, and now congestive heart failure, and cancer is now a treatable disease. Many types of cancer become chronic diseases as people live longer with them. Additionally, diabetes is growing at rampant levels in this country. Experts predict 1 out of 3 children born in urban areas today will be diabetic. Diabetics have tremendous complications. They have kidney failure, they have cardiovascular disease, they have strokes, and they also have blindness. Furthermore, obesity in this country is going much faster. I just heard, as I was driving down today, I just heard that 1/3 of the children between 10 and 21 in this country are morbidly obese. That's a huge number. I was shocked when I heard it. But that's what's coming up to our healthcare system. Exercise and diet, we talk about it, we see it publicized. It's really a very small number of our population who really values diet and exercise. Poor health behaviors contribute to chronic diseases. There's no question about it, well documented. And we don't have wide practice of health behaviors. All of these chronic conditions create a tremendous stress on our healthcare system. A healthcare system that is designed for acute care. People get sick, they go to the emergency room, and they might be hospitalized or they might be discharged to home. Our emergency rooms are bulging. You hear all the time, and you may have experienced going to an emergency room and waiting for as many as 24 hours in the emergency room, and maybe sitting there for days before you can get a bed. And now as we look at this flu epidemic that everyone's talking about, if this does happen, if people don't get immunized, and it does happen, our emergency rooms will never be able to handle the number of patients coming into them. So focus on acute care is who we are and what our healthcare system is about. Our healthcare system is not designed to prevent disease or to manage chronic conditions. And consequently, our healthcare resources are not and will never be able to care for the number of elderly and chronically ill Americans that we have in our country. It is time to move away from our current focus on acute care and really look at models of care that prevent disease from happening, and secondly, manage chronic disease in the best possible way. Many of you, I know I have elderly parents living at home. It is so difficult to get primary care for them because it's difficult to get them to a doctor's office, and I can't get anybody to come into the house to see them. Doctors don't want to take the time that it takes to make a house visit. That whole group, as it expands, the very few doctors who do make house visits simply won't be able to do it. 75% of all health care costs in this country are attributable to chronic diseases. So if we manage chronic diseases, just think of the health care costs we could reduce. These models require appropriate resources in both funding and in personnel. With the vast majority of health care costs generated in acute care, there is a great necessity in this country to shift both values and dollars to disease prevention and chronic care management. We need to look at models of care delivery that address this. There are now in this country creeping up many urgent care centers, we call some of them we call clinics, that have started as a way of shifting some of the care out of the emergency room. Many of these models are run by advanced practice nurses or physician's assistants who work in collaboration with the very few primary care docs we have. Because frankly, the number of primary care doctors we have in this country also are not sufficient, nor will they ever be sufficient. We just don't have enough people going into primary care. And with the cost of medical school, we will never have a workforce that's going to be able to take care of the people coming into it. When we look at the baby boomers coming up, when we look at diabetes, and also when we talk about this number of insured people that might be entering the area of being actually insured, they want access to a healthcare system too. So then we're adding another 25 million people with insurance who say, hey, I'm here and I want access to this system. So I think the clinics, as they have evolved, is a way to shift the care out of the emergency room so that you don't have to wait. So maybe if you have a sore throat or you have a urinary tract infection, you think, well, I'll just go to one of these clinics and get my care so I don't have to go to the emergency room. These clinics are a perfect place to have an interdisciplinary team of advanced practice nurses, physician's assistants, and other healthcare providers who work in collaboration with primary care docs and provide disease prevention, immunizations, keep track of records, and also manage chronic diseases. They need to be connected, as you suggested, by electronic medical records so that there is a way to share information wherever the patient goes from there. This frees up the doctor to do what he or she does best, and that's to manage exacerbation of disease. When diseases get beyond the scope of practice of the other health professionals, this is where doctors are needed, and we just don't have enough of them to spread them across the whole spectrum of healthcare. Acute care is expensive. It is very expensive. With good focus on prevention of disease and disease management, we can take a lot of the dollars out of that acute care reimbursement system, focus it on building a more healthy population, and focus it on managing those chronic diseases which are only going to become more rampant in the years to come with our aging society.
Thank you, Tara. Some of the things that are out there that the experts offer are interesting, and they fall in line really with what Sandy and Tara were talking about. But I just want you to keep in mind the legislation that's currently in Washington is looking at the cost-saving potential of prevention. They're also looking at comparative effective research. In other words, if we do this, what is the outcome for the population that we treat? Is it the best way to go? They're talking about disease management, as Tara just offered, and they're also talking about healthcare information technology. One of the problems with all of these issues is there's really very little evidence out there yet, because we really haven't done them to any degree, because no one's ever paid for prevention and to keep you well, is will we save the money that we believe we will if we do this with our populations? The American Health Insurance Plan came out with a model in 2008, which is not really on the table in most of what we're listening to, but does go back to the shift, what they call a shift in the malpractice system to a dispute resolution system. And this would be a rapid resolution of things that patients bring forward. It would provide, as they write it up, fair compensation for patients and would provide legal protection for clinicians who are practicing evidence-based medicine. So that would deal with some of what we're looking at, but that really is not something that they're willing to tackle right now, or at least Obama has put that off into a committee, I think, in HHS. Physicians themselves, from a study that was done by Mount Sinai in their research arm this spring and this summer, did a random sample of almost 5,100 physicians that were on the AMA master file list. 63% of the physicians supported both public and private options, and the primary care physicians in this group were most likely to support the public option, which is important in terms of what we're looking at. They also talked about the expansion of Medicare coverage to the near elderly, and again, the primary physicians were out at about 65% in terms of supporting that. One of the things we hear a lot about is American values, in the sense that, well, you know, an American wouldn't support a single-payer system like Canada, and we hear that a lot, rhetoric, quite often. Ezekiel Emanuel, who's a special advisor to the Obama administration, proposed a rather unique idea, but again, I don't think that's gone anywhere. He proposed universal health care by adding the value-added tax. You know, the VAT, if you've traveled to Europe, you know that's on goods that you've bought. His belief is, by running the numbers, that that tax would actually support universal health care for everyone. Fee-for-service, tough topic to discuss. Again, one of those things that's not really in the Obama legislation or what either one of the houses are bringing forward. The CBO said that really if we could do something to significantly change the fee-for-service system, that indeed that could pay for health care. There was a suggestion that came out of a group that worked with Robert Wood Johnson in a pilot study 2 years ago, and they call their method the Prometheus payment method. It will bundle services. It would use evidence to say this is what this should be paid and this is what should happen. It would be adjusted for severity, and potentially the group, after their pilot studies, believes it could save us $700 billion over 10 years. That would almost pay for the program that we're talking about. The state of Massachusetts, you've probably seen them off and on in the headlines in the last couple of months. In 2006, they put in an all-payer system. Less than 2.6% of their population are not covered, but what they have realized within this last budget year is they cannot afford a fee-for-service system. They're going back to a system where they're going to hope to pay for it by risk adjustment and a pay-for-performance system. They want to reward people or practices for provisions of accessible and high-quality care. This is a system where the government is a payer, the payers as the insurers, and the providers are going to share responsibility to build a system and make the transition. One group of, actually it was a couple of researchers at Harvard, came up with what they call the innovator's prescription. It is their disruptive solution for healthcare, and they talk about three groups of healthcare. Precision medicine, which essentially they said is rules-based, so the kind of things that Tara talked about, that the nurse practitioners, physician assistants could work well with a primary physician in doing things that are very precise, the strep throats, the uncomplicated bone fracture, those kinds of things that there are some rules that say, this is what presents, this is what you do. Their empirical group is going to cover diseases for which treatment outcomes are pretty probabilistic. You kind of know what's going to happen when someone comes in with a heart attack, when someone comes in with a stroke. And that would be a network group of professionals trained to work together, again, what Tara was saying, with chronic diseases, because that's what those things would be. Their third level was what they call intuitive medicine, and that would describe conditions that are really coming up with symptoms and have to be treated with therapies that have uncertain outcomes. This could be people with depressions, multiple sclerosis, lupus, and a whole group of diseases we really don't have a track record that says, if we do this, this is what's going to happen. The insurance exchanges, some of that is probably going to be in this language one way or another. I didn't see the new language that they say there's something in there for the public option. And actually, last but not least, I'd like to put on the table nursing. We have mentioned some of nursing in terms of the expanding roles of the nurse practitioner, which Pennsylvania has made very good use of. They can work in the medical homes, telehealth, and those things that we're seeing recently. And the last thing that nursing is looking for as we move forward in primary care is to make sure that nurse practitioners are included as primary providers in the language. With that, the floor is yours. Dr. Moll?
The things we're saying are all fielding the ball when it comes to third base. It's like what happens, rather than say, let's prevent that from happening. It's true that 70% of our diseases are chronic degenerative disease, 80% of it cause. The fact of the matter is, lifestyle change can affect a lot of these. Stress management, exercise, diet. And we don't really address that at all in our bills, in our plans, or anything else. And you know, what's really going to happen is we're going to add more 5-minute interviews to patients for $30 a visit. Because that's what's happening now. Because the way the insurance is structured, the doctor can't spend more than 8 minutes with you. And if the nurses or the health practitioner, or whoever you call it, do that same dance and step, we're going to wind up with the same problem. You know, when you talk about 25 million people getting insured, $10,000 a person, multiply 10,000 by 25 million, you go $250 billion yearly. So let's look at focusing on health professionals who are not physicians, not nurses, but educators and motivators, because nobody's picking up the nickel on this. Nobody's taking the responsibility to say, this is my problem as a patient. The supplier's to blame, the provider's to blame, the payer's to blame, the patient's to blame. The patient has to be proactive, take responsibility for their health. And we need educators and motivators who would have a science background, perhaps from nursing, perhaps from biology, and then take a course in learning how to motivate and educate these people to reduce their incidence of chronic degenerative diseases. Because this is what's happening. What do you think? Obesity is a disease that suddenly we all caught, or diabetes we all caught? They're preventable. They can be treated. They can be prevented, ameliorated by lifestyle changes. And we need educators and motivators to teach our public to be proactive, to take responsibility for themselves so that we can have a healthier country. The reason why these other countries they're spending half of what we have to spend is because they're healthier, because they're more active in their own care. Germany has a wonderful system, but Germany, if you lose your case, your malpractice suit in Germany, you have to pay the doctor's court fees and his lawyer fees. There is no such thing in Germany as a TV ad about a drug. We're the only country that allows it. New Zealand tried it for 10 years. They went broke. They said we can't afford it anymore. In 2006, they stopped. How can you advertise things in the advertisements and not have people come in and say, this is what I want? And if the doctor has 8 minutes, he's going to give them a prescription to get them out of there.
I'm sorry, what did you say before? We're the only country that does not?
New Zealand did have advertising, and they stopped it. So anyway, what I'm saying is, let's not focus on, who's going to catch the ball. Let's prevent this from happening by having people, educators, train and educate our people, not have more extended docs to give you an x-ray, a blood test, or a pill. Because, I believe a lot of what we call diseases are not diseases, they're disorders. Because a disorder is something that your life is out of order. If you can reorder your life, and we can help you do that, then it's not a disease. Why would you take somebody with obesity or cholesterol or hypertension and label them forever to have a disease when it can be, we know that 90% of the time it can be treated effectively with lifestyle changes. So,
Thank you, Dr. Lamont.
Next question.
answer, maybe?
Let me just run over with the microphone.
I have a question, and I work with a bunch of people in a very disadvantaged community. I totally agree with the comment. We need some patient accountability. That's the part that's not discussed. Our families that I work with use the ambulance to go to the hospital, whether it be for a cold, a hangnail, or whatever. I believe you need some skin in the game, even if it's $1 a visit. Something so that you maybe take better care of yourself, take better care of your kids. That's just an opinion, and separately it came from the medical device industry before I moved into working with people. And you can't get medical devices because of tort issues. You can't get them online. We spent more time with attorneys defending our devices that were saving lives than in making the next generation of that device. So tort reform somehow just gets around the edges and not really talked about, which I think is atrocious, but that's the life we live in. My question is the following. There's a lot of comments about there's so many uninsured people in the United States. I work in a community where there's a lot of people who should be on Medicaid. They have not filled out the form, but I know of nobody that has been turned down when they come to the hospital. So I'm submitting that there is a little bit of a red herring here when we talk about the uninsured who are not getting care taken. Question to you is, how often in your experience, because someone does not have insurance, do they get turned away?
I'll start it and then we can move on. There is a law protecting people who come to the emergency room, of course. So anyone who comes to an emergency room for treatment must be seen. They could be discharged if they don't need to be admitted, but they also might be admitted even if they have no insurance, because you can't, once you see them, you've got to, of course, see them through. So you're absolutely right, but they're seeing care, and that's why it's one of the reasons why emergency rooms are bulging, because so many people who don't have insurance, it's their only route and access into the care system.
Let me throw out a couple of thoughts that probably related to the geography that you live in. And for those of you who don't know, Temple University Hospital sits in North Philadelphia, and the families around our hospital live at the poverty rate 3 times the national average, and our high school graduation rate is 50%. Temple sees the highest volume and highest percentage of Medicaid recipients in the Commonwealth of Pennsylvania, and we're right up there with LA County. Now, I say that because I'm going to use that to preface my comments. This is really a 3-pronged system. It's not a public and a private system. It's a public system, a private system, and a safety net system. And for the lay universe who worries a lot about the 50 million people who are uninsured, and God knows we provided $60 million of free unreimbursed care last year alone, plus the 80 cents on the dollar of cost in order to provide 50% of our business. So I have great regard for those healthcare challenges that Tara has talked about. But there is a safety net system in the Commonwealth of Pennsylvania and in the United States. That's why the healthcare system has not fallen apart since Medicare and Medicaid started. We've got to bring the cost down, but it's still working. You know, that's why it's still working. And so, yes, there is an EMTALA law that says when you come to the ER, we have to care for you. But if you're a private practice orthopod on the main line and I show up with Medicaid, you get to turn me down. And so from an access standpoint, the insurance thing first starts with access. If patients work and live in an area, and whether they have Medicaid, let's just use the public insurance for a second, individual providers have the right not to see them. And so, for example, a place like Temple draws 14% Medicaid out of the main line. Only 3% Medicaid gets cared for in the mainline system. So there's an access barrier that plays in lots of communities. In part, it's socioeconomic. In part, it's languages. Spanish is your first language, not English. There's reasons that folks gravitate. That's thing one. Thing two is, of those 50 million folks who are uninsured, when they come to the hospital, there's a mechanism to be insured while you're in the hospital, for us to get paid, and for you not to have insurance when you go home. So there is a whole safety net reimbursement system under the federal government and the Commonwealth, and it's called disproportionate share. And it's some of the language you hear of the federal government wanting to bring down disproportionate share. And so the places who are safety net hospitals, the free clinics, federally qualified health centers, the providers in your community and Temple University Hospital work in that safety net space. And so it's a slice of what's going to happen as healthcare reform moves forward, because safety net providers need to deal with those 50 million people who are uninsured, many who are well. Think about the last time you all went to the doctor. Not everybody in this room went to the doctor in the last year. Maybe not in the last 6 months. Not everybody needs to go to the doctor every 10 minutes. And so when you're in an environment where you don't know how to optimize regular healthcare, you call the ambulance and you come in. Because you know what? We can't turn you away. So there's a part of that is our stewardship obligation. It's what our obligation is to provide that care, but there is that other safety net piece out there.
Thank you. We have time for one more question. Because we are leaders, and I want to say two things. Number one, we have to start with the youth. We have to educate children at age 3, 4, 5, how to eat, how to exercise. But the other piece to this, as the mother of young adolescents, college graduates, we as leaders can't have these individuals working 20 hours a day. The goal out in society right now, I have children in finance, law, and so on, is, keep working harder, keep working harder. I manage at least 50 people, and I make sure that they're out the door by 6 o'clock at night. They need to be home with their families. They need to be exercising. They need to provide good nutrition, and they need a good family life. And I think that's the elephant in the room. I think we all really need to look at that. Thank you.
I think in closing, what we need to remember is that the federal government cannot fix all these issues, and I don't think as leaders you want them to. Do we have one more question?
Chris? Yeah.
Oh, I'm sorry. I can't see her. I'm sorry. You're not in my eye focus with this.
I actually want to bring up a little different topic, and I always feel compelled to do this because I am in the military, and I guess I'll turn around. So it's something for you all to think about. Many of you may have served. Some of you may still be serving as reservists. But in the military today, in every war, there are premier changes in medical practice. For World War II, it was antibiotics. For Vietnam, it was abdominal surgery and vascular surgery. For these wars that we are presently in, it is two issues. Amputee care and the rehabilitative care is blown us away. I'm sure many of you have seen the shows on C.N.N. and 60 Minutes about the robotics. They are now improving on a hand that will actually be able to be mobile, facile, pick up instruments, cups, whatever. We are cloning a finger as we speak today. So it's dramatic what we've done for amputee care. And I think for you to understand that, because we will transcend that practice to all of you in the future. So as our diabetics need amputee care, as unfortunately our children get in car accidents and have trauma, we are going to improve that care as well. Another cost to think about. The one area that we're not doing so well in, and that is going to have dramatic impact on all of you and all of us for the rest of our lives, is, what do you think? It's mental health. We have spent millions of dollars and continue to spend $1 million on traumatic brain injury and psychological health research. I can tell you we are not very far ahead in where we are going to be in the future of caring for our veterans. The long-term effects of concussive injuries, the exposures, the continued exposures over time and distance of IEDs, explosion devices. We have men and women who have gone back to a war 4, 5, 6 times. I met a gentleman the other day who has a fractured femur. He had a bullet through and through his arm, and was proud to tell me that he's been in 5 IED explosions at various distances. We do not know what impact that will have on him for the rest of his life. Not just in terms of the concussive effects, but in terms of his mental health. There's co-occurring PTSD. There is the potential for memory changes, balance changes. We are finding more changes in sight, long-term, blurred vision, all kinds of things that we don't know about today. And the other issue is PTSD. I will tell you that we do a lot of reassessments. Every one of our soldiers and sailors and Marines who come back are reassessed 6 months after they've returned from deployment. Sometimes we pick up the PTSD, but I will tell you, if you talk to your Marines out there, we don't see the effects till 8, 9, 10 months, sometimes a year, sometimes 2 years later. So we may not see it, but you may see it. And we don't have a lot of good answers for that care of that veteran. So I share that with you because, in my opinion, PTSD is not a military issue. I mean, how many of us have stressed over the fact that our IRAs went in the toilet, or that our kids now can't go to college, or when your 16-year-old drives the car for the first time? So we have stress, we have PTSD. We don't have very good ways to take care of our people. And so I just want to share that with you because as we transition and as we find better ways, much of what we're doing today is resiliency training so that we, you know, someone talked about it's the patient's responsibility. Well, we feel it's our individual service member's responsibility not only to know the signs within himself or herself, but the signs that their buddy may be showing, that it's time to stop, move away, and get some help. Because we've demystified it dramatically over the past 5 years, and we've destigmatized it. But I will tell you today that most of our Marines still feel like they can't tell you that they're just not doing real good. So I share that with you and hope that we continue to partner because we've got a long road ahead of us to heal our major heroes of this war. Thanks.
Thank you.
As you go back to your communities and what you do in life, remember that what we hear in healthcare reform and what's going on in Washington is only a small piece of the picture. Some of the things you heard from the panel as well as from yourselves is there has to be a preferred future for healthcare access, and each of you can play a role in that on a state level. There are things we can do for healthcare in our states that will make a difference. You and I know that anytime the federal government gets their hands on it, it costs us more money and everything else happens. We can do some very exciting things within our own states and communities.